Okay, so this morning we got as far as hypothermia. We had talked about hyperthermia, and before that, just thermoregulation. So, talking about hypothermia specifically, we were able to touch on the different severity levels of hypothermia. Hypothermia is defined as a core body temperature less than 35 degrees Celsius, which is 95 degrees Fahrenheit. So there's mild, moderate, and severe hypothermia. Severe is the most significant, as you may have guessed, because we begin to have death of cells, tissues, and organs. So the clinical manifestations of mild hypothermia include shivering or muscle movement, muscle activity in order to produce heat, tachycardia and tachypnea, which is increased respiratory rate, so increased breathing, and heart rate speeds up in effort to try and pump warm blood through the body. Other signs and symptoms include fatigue, just feeling tired, slurred speech, poor coordination, poor judgment, just not thinking right or not being logical, and inappropriate behavior. And we said that that was defined as behavior inappropriate for the situation, undressing or being belligerent or not speaking or just behaving in an inappropriate manner for the situation. Clinical manifestations of moderate hypothermia, now we don't have any shivering, okay, because the muscle or the tissue on top, the skin has started to freeze. So no more shivering. Respirations, which were previously high or tachypnic, are now decreased, and we have decreased respirations. Heart rate also slows down, can have an irregular heartbeat, low blood pressure, pale, cyanotic, remember, because we have vasoconstriction as we try to create inward heat. At this point, the mental status is extremely depressed and may start hallucinating, so more so than just acting inappropriate for the situation, now we're completely hallucinating that they're in a different situation, or maybe in a coma. Severe hypothermia is we've got cell death going on. So there's absence of respirations, not breathing, no pulse, ventricular fibrillation, the heart has some electrical activity but no organized cardiac rhythm. Pupils dilated, patient but unresponsive to light, patient is in a coma. The biggest thing to remember is, when does shivering stop? Remember that at first we're high heart rate, high respiratory rate, still awake but can be confused and tired. In moderate, we've stopped shivering, respirations, pulse has slowed down, heartbeat can become irregular, very pale, cyanotic, meaning blue. At this point, don't even know where we are or in a coma. And then severe, no respirations, no pulse, and no organized cardiac rhythm. Other thing to remember as well is, more so than based on core temperature, we classify this hypothermia, classify all hypothermia based on clinical presentation. So there's a staging of hypothermia, and that also talks a little bit more about clinical presentation. So general nursing interventions for hypothermia, of course, we're going to monitor vital signs, because there are going to be fluctuations in vital signs as our body initially tries to compensate and then it can't. Assessing skin color and temperature. Removing, I don't think I have it on here, but removing any wet clothing, any cold clothing, best to get that off. One of the things I was taught in winter survival is that you don't want to purposely make yourself sweat, so you don't exert yourself, even though, yeah, it's a way to get warm, because if you get wet, then you're more at risk for hypothermia. So any cold or wet or damp clothes, want those off. get the patient in warm blankets or clothing, warm environment. We want it to be at least 81 to 82 degrees. Our perfect temperature, our body loves 81 to 86 degrees. Put dry clothing on them. Have them do that fetal position we were talking about, limbs close to body, to help circulate blood into the trunk. Cover the head. Excuse me. Remember, we're losing heat out of our heads. If your feet are cold, put a hat on. Hyperthermia blanket, so a heated blanket. Warmed fluids, whether that we're just talking about hot tea, hot coffee, hot cocoa, something nice and hot and warm, hot broth, something of that nature, or hot or warmed IV, not hot, warmed IV fluids. So this is accomplished. You can put IV bags of IV solution inside of the blanket warmer, and that will warm them up, and then you can give them to the patient. Hopefully there's some already pre-warmed. And then a heating lamp, heating pad, or hot water bottle. All ways to help warm a patient up. So when the treatments vary as far as what's priority depending on the severity of the hypothermia. So in mild hypothermia, we can, of course, get the wet clothes off if there are any, or damp clothes, which normally they are, especially if you've been out any kind of cold wind. I'm sorry, excuse me. I'm thinking about warm and coziness. Warm blanket, provide that warm environment. At least 82.4 is the perfect degree, but the range is 81 to 86. Warm compresses to the neck, chest, and groin. Remember, we talked a little bit about, why did I put chest? Sorry, it's not supposed to be chest. Maybe I meant under the armpits. And then, because then I wrote, do not apply directly to chest, trunk. Sorry about that. Just the neck, axillary area, and the groin. Give them a high-calorie, warm beverage. So high calorie doesn't necessarily need to be good protein or anything. They're using up calories because they've been shivering and using up nutrients. So just a high-calorie, warm beverage. And then the rewarming rate for patients who have any hypothermia is to rewarm at a rate of 2 degrees Celsius per hour. We don't want to rewarm people too fast. With moderate to severe, we do the core rewarming as the same as mild hypothermia, but because cell death and tissue death can have occurred, as well as organ dysfunction and organ failure, we may have some associated symptomology to manage. So you would, in moderate to severe hypothermia, you would add that management of those, and then if there was any frostbite, we would rewarm those digits in a hot bath. And I'll talk a little bit more about frostbite in a little bit. So our priority is to start rewarming, get the patient rewarming, stabilize vital signs, so that can be through administration of fluids, oral and IV. As the patient warms up, it's normal for them to feel a lot of pain and a prickly sensation, so pain medications may need to be administered. As I already said, treatment of associated problems, depending on the severity level of the associated problems and organ failure, this may or may not take some move up in priority after hemodynamic stabilization. And a lot of this is going on all at the same time. You know, we're not going to rewarm our patient and then wait and be like, well, I know your blood pressure is crap, but you're just going to have to wait until you're warm again before we can give you any fluids. These things are happening very quickly all together. Start the rewarming process, get the patient stabilized hemodynamically, administering pain medications, and figuring out running diagnostics and finding out what's going on as far as how the extent of the internal damage, and then creating a treatment plan based on that. And then, depending on the level of frostbite, may have to have debridement or amputation of the frostbitten limbs. So what puts someone at risk for hypothermia? Well, obviously, we were talking a lot about outdoor exposure to a wet, cold wind, or just getting wet, and then the wind and the air. So obviously, those are all risks, but even being inside and just being of low socioeconomic status, not being able to afford proper heating or central heating can also put one at risk. Traumas, especially I think about the road from here to Sonora, and any traumas or vehicle accidents that happen along the way there, and the tremendous loss of body heat, maybe through just being exposed to the elements, plus any kind of like hemodynamic injury or loss of body fluids or blood, like massive hemorrhaging, can put one at risk for hypothermia. We talked a little bit about neurologic impairments and autonomic dysfunctions in relation to heat. Also remember that the pituitary gland is also closely connected to the hypothalamus, and so endocrine disorders like thyroidism, hyper and hypothyroidism can affect hypothermia. We talked a little bit about alcohol and how that's not really warming. Some skin disorders, social isolation, just not, again, this is more like the elderly, not having someone come looking in on them, and alone, and not having proper access or not realizing that they're too cold. Sepsis, especially in the elderly. Burns, patient is at risk for hypothermia, burns. And then, of course, age. We talked a lot about newborns and the elderly, this population today. So some lifespan considerations with that. So remember that the newborns have large body surface area. That's what BSA stands for, body surface area. So they have most of their skin and everything, or their body surface area, is all over their trunk. So they lose a lot of heat from here. They lose heat because of their lack of subcutaneous fat. They lose heat 4 times faster than adults. There's no shivering involved in infants unless their basic metabolic rate is doubled. So normally we said, like in fever and stuff, the BMR will increase like 7%. We're talking about doubling. Other than that, they have the non-shivering heat production from brown fat. So children and adolescents also have a large body surface area compared to, they don't have bigger trunk area. There's the knowledge deficit, just being a little kid and playing outside for hours on end, not knowing to stay hydrated, to come indoors often. Their little noses and heads and hands get cold, but they don't think about it because they're busy playing. So might have a knowledge deficit and therefore are at more risk for hypothermia. Low glycogen stores to help produce or burn energy for to increase their BMR, and so they easily become chilled. So wrap your kids up, put a hat on them. It's good for them. Pregnancy, just an FYI, is a contraindication for therapeutic-induced hypothermia. We don't want our pregnant ladies to get too hot. We don't want them to get too cold. Older adults, remember that they have this lack of physiologic reserve, and I have some notes down here that's all this stuff. So we're talking about decreased thermoregulatory efficiency, inadequate diet, loss of sub-Q fat, illnesses, CNS disorders, diabetes, peripheral neuropathy, things that affect circulation like that. Hypothyroidism, that's an endocrine disorder, certain medications they take, just in general, reduced sensory perception, and other cognitive disorders like dementia and Alzheimer's. And then also sepsis. We had touched on this morning that sepsis in a normal healthy adult, you'll have a result of a fever, but in older adults, actually be hypothermia. So one more video after this, guys.